So let me know if you can see these slides. I hope you can.
Yes, we can.
Yep, excellent. Okay, good. So I'm going to give you a real whistle-stop tour. I'm so sorry that I haven't been able to join you for the rest of the program, and I'm hoping I'm not going to duplicate anything too much, but I've got lots of slides because I'm a medic and that's what medics do. We like slides, and I'm going to really scoot through them very quickly. But essentially, I was involved in the Mental Health Act review in particular. I was involved in a number of areas, but in particular, I was involved in the area which was the working group around Black African and Black Caribbean people and the recommendations. And what I'm going to do is really just go over what we found, because we did huge amounts of work in terms of getting the evidence and trying to understand the evidence to try and help us determine what the recommendations should be. Those recommendations have now been taken up and are in the Mental Health Act reforms. So what were our findings? Essentially, I'm sure you've already heard this, but there are profound disparities in access, experience and outcome for Black, Asian and minority ethnic people, particularly for Black people in terms of being overrepresented in crisis and in secure services. Although being overrepresented in crisis, very much underrepresented in treatment. And actually, if you're any ethnic minority, you are much less likely to be offered psychological therapy. You're much more likely to drop out of psychological therapy, and that's for all ethnic minorities. And in fact, for people who are from South Asian backgrounds, even though there's lots of presentations to primary care, trying to get into secondary care services is virtually impossible. It's really very difficult. What we did, there was a number of evidence. There's quantitative evidence, there's qualitative evidence that was commissioned actually, and one of the studies was a systematic review and meta-analysis of again detentions under the Mental Health Act by ethnicity. And what we found, again, this is a Barnett study. What we found again is that if you are from an ethnic minority background, then you were much more likely to be detained, and that included people who were from white other backgrounds as well, and all migrant groups. And this was an international study, so it didn't matter, you know, what country you were in. If it was a white majority country, if you were from an ethnic minority, you're much more likely to be detained under the Act, you know, or involuntarily, depending on what your jurisdiction is. The thing about that study is that, okay, you could say nothing particularly different there, we know that already. But what we did in that study, this is a female Bartlett study, and actually it was published in Lancet Psychiatry, thank you, Niall. What we also did in that study was to look at the explanations that were given by the authors, by the researchers. And of the 70 papers that we whittled the review down to, almost 50% offered no explanation for why there were these disparate risks of detention for minority groups, or offered explanations that were unsupported by primary evidence. So, and what that meant was that, so people were basing their finding, that, you know, they were basing their conclusions on no findings. They were saying, well, yes, again, here we see that there are higher rates of detention in ethnic minority groups, and that's probably because you know, Black people are more violent, or probably because they're taking more drugs, etc. The problem is that those explanations were not tested. They weren't based on any evidential support, and those untested explanations tended to deal with stereotyped assumptions of minority ethnic groups. And we felt that these untested hypotheses are of limited use, especially because they were also based on quite heterogeneous groups of people, as though they were all one. So, for example, we know that particularly South Asian groups, lots of different types of South Asian people, different types of Black people, but everyone was lumped together. And, you know, there was no taking account of intersectionality, etc. One of the biggest problems was that of the explanations that were given, they recurred again and again in the studies that followed. So a study would say Smith et al. In 2009 found that there was an increased risk of detention, and this was because more Black people smoke drugs. And then the next researcher in 2014 would say, oh yes, as we can see from Smith et al. And Jones et al., they found that more, and so on. And that just propagated erroneous explanations. So just to remind you that the etiology of mental disorder, genetics and familial inheritance and some biological factors are important, although even with perinatal factors, they might be driven by some of the, some societal aspects. So your exposure to toxins, for example, air pollution might be impacted on by where you live. And if you live near a motorway, which most people, if you're pretty affluent, you try not to live near a motorway, that might have an impact on you. But a lot of mental disorder is actually related to, trauma, like physical, psychological, sexual trauma, adverse childhood experiences, earlier persistent substance use, negative life events like bereavement, etc., social isolation, and we've certainly seen that in the last year, and poverty. I always think about the state of being impoverished. So the question is, why is it that people in certain minority groups have worse mental health? And this is what we were thinking about when we were trying to develop the recommendations, because it would just be too, the idea, it was a rather simplistic idea that somehow psychiatrists and social workers see someone who, is brought to them and just decide, yeah, I'm just going to detain them because I like detaining people. It's just not as simple as that. And it was pretty clear that lots of people who were being detained had problems that had started many years before, but were not being properly cared for at an earlier stage. And there were other people who probably just didn't need to come into hospital, but we needed to understand what was going on. So the question is it to do with genes? Is it social factors? Is it discriminations? Some other psychological factor? Was it all of the above? So what about genes? Well, what we know is that, when we looked at it, there's various studies. We know that there's a WHO study, a very famous big study, showing that rates of schizophrenia are 1% across the world, regardless of whether the country is a white majority country or black majority country, which kind of makes you think what's going on in places like the UK, Netherlands and the USA, if in black majority countries, rates of psychosis and schizophrenia are 1%. Robin Murray pointed out many years ago, actually, that the rates of psychosis in second generation people, children of first generation immigrants, are much higher than in the first generation. So it will be odd that your mum and dad's rates of psychosis are, say 1%, yet the children's rates are 4%. That again kind of makes you think that's probably, genetic. That doesn't look like genetics. And then this study, this is Sherifat Aduola, recent study. They've been looking at rates of psychosis incidence over time. And what they found is that actually rates of psychosis are increasing over time. Actually, this is a South London cohort. And this is they looked at the incidence of psychosis in the late 90s, and these are the rates that were seen. And I've just picked out the white British and the black Caribbean people here. And then about 10 or so years later, they looked at rates again, and the rates overall had increased. But when you broke it down by ethnicity, as you can see, the rates in the white British people had increased. Interesting, the rates in the black Caribbean people had decreased. You would be surprised to see that kind of level of change if it was simply genetics. The genetics just don't seem to explain the higher rates. And I say that because there is often this underlying unsaid thing that the reason why black people have these higher rates of psychosis is because it's a genetic thing, simple. And I'm not sure and that's a bit too easy. And that's what we thought, this is too easy. So this is a slide just showing the social determinants of health, and you've probably heard about all this already, but just to remind you that if you are lucky enough to be born into a loving family with parents who, nurture you and care for you, and you don't experience too much adversity as you're growing up, you live in a comfortable house, you are educated at a nice school, you have kind people around you who support you, in addition to your main caregivers, as you've got teachers and other supporters, grandparents, etc. Your family have a comfortable enough income so that they can provide you with good enough, healthy, nutritious food. And then as you grow up, you're lucky enough to have a stable employment that's not precarious, or, you know, you have employment, and that you live in a community where, you know, if for some reason you live on your own and you fell down the stairs, that someone would notice that you hadn't been around for a day or two, and they'd come and knock on the door. And when they found you with your broken leg, they'd take you to hospital, and you could get there really quickly and get access to your health. If you have all these things in place, then you will have much better health outcomes. And there's very good evidence of that. Public Health England produced this, you know, inequality pathway, if you like. And essentially they said our social position in society has a material effect on our standard of living, and that affects our health behaviors, it affects our community, our neighborhood, and all these adverse and protective psychosocial factors, which actually impact on what our health outcomes are going to be. And in fact, if you look at this, you can see that this is a slide showing that if you are from a poorer background, then you actually have a much higher rate of mental health problems. And if you're from a more affluent background, it doesn't mean to say you're not going to have a mental health problem, but you are much less likely to have a mental health problem. And just to remind you, and this is the important thing about heterogeneity, that, you know, I don't like this term BAME, and that's because it stops people thinking about all the different individual types of people, and even these groupings are not ideal, but you know, it is what it is. This is a slide just looking at income, actually, and if you look at median income, that's median is in the blue, and you can see that if you, this is white British at the bottom. If you are white British, then you're relatively wealthy. It's pretty okay. And if you are Black African or Bangladeshi, then you actually are much poorer. Interestingly, of course, if you lump everybody together as South Asian, then what you miss and what's masked is the fact that if you are from of Indian origin and you are South Asian, then your income level is likely to be very similar, if not slightly more, than someone who's from a white British background on average. Whereas if you're Bangladeshi, you're actually likely to be really quite poor. And that has a significant impact on your health, because these group of people are much more likely to spend a third of their lives living with poor health, compared with this group of people at the bottom, who are much more affluent, who spend about a sixth of their lives living with poor health. So how might social factors be associated with mental disorder? So this is Shah and Mackenzie et al. They talked about vulnerabilities and resilience factors occurring at both an individual level and an environmental level. So the environmental level being, you know, where you live, which is of course impacted on the group that you belong to, what the laws might be, how easy is it to live the lifestyle that you want to be able to live. So for example, about 20% of Jewish people in Britain live in the Barnet area of London. And if you go to the Barnet area of London, it's much easier to live a kosher Orthodox lifestyle, because the shops will provide kosher food, they'll shut at certain times, etc. It's much easier for you to live according to your cultural mores than it is if you were to live in, you know, for example, if you were to live in Surrey. The interaction between your individual risks and your environmental risks are not independent. Your social, for example, your social context changes if you lose a parent when you were young. And then there are sensitive periods in your development, because your resilience changes with age. So this 4-dimensional model might give some understanding as to why social factors might cause mental disorder. What about discrimination? Is this a risk factor for mental disorder? Just to remind you, you know, we've got individual, you know, discrimination. In this case, we're talking about racism, but you can, you know, substitute discrimination for racism. This is Kamara Phyllis Jones. Kamara Phyllis Jones's definitions. I think it's quite a useful one. The individual stuff, the personally mediated, that's the overt, covert stuff, you know, calling people names in the street, etc. Prejudice is based on the assumptions, negative assumptions usually, that you'll have about the abilities and motivations and intentions of others according to their race or protected characteristic. Discrimination is the behavior that you mete out against another because of those negative assumptions. And it might manifest as a lack of respect or devaluing people, being surprised at people's competence because they're Black, that kind of thing. The point is that it is associated with a negative emotional response and a physiological response to stress. The institutional structural racism, this is, you know, when you've got differential access to goods and services, etc. I'm sure you know all about this. And very importantly, it's often seen in inaction in the face of need. And I think this is particularly important when it comes to mental health. And then the internalized racism is that when those who are stigmatized accept the negative assumptions about their abilities and intrinsic self-worth, which, you know, does lead to low self-esteem and low self-worth, and is related to this theory, which is minority stress theory, described by Ilan Meyer, which is the internalized homophobia and stigma that results in actual experiences, you know, resulting from actual experiences of discrimination and violence, but actually is associated with increased risk of anxiety and depression. Okay. And of course, Robert Carter's talked about racial trauma, and essentially what he's a psychologist in America, and he said that the cumulative effects of racism on individuals' physical and psychological state is basically it's a psychosocial stressor. It affects health, and you can get symptoms similar to post-traumatic stress. And people are looking into this, but it does look like discrimination might be associated with anxiety and depression, and maybe even suicidal ideas. Question is it associated with a psychosis? And Josie Peirce et al. Have found out that yes, that looks like there might well be an association with discrimination and psychosis. So they found that there might even be a dose-response relationship with this. So the more discrimination you experience, there might be an increased risk of psychosis. And Hannah Jongsma, this is James Kirkbride's group, found that social exclusion and social disadvantage was also associated with psychosis risk. And in fact, adjusting for this led to almost equivalent rates of psychosis in minority ethnic groups compared with white majority groups. So that's pretty important, because then it starts to tell you that maybe what we've been doing over time is not thinking enough about the social and discrimination factors that might be really important in some of the excess rates of psychosis and the excess rates of mental disorder. And that might be something to do with and the fact, and also that has a bearing on how much support we're giving people and are we giving people the support at the right times. And what we were thinking when we were you know, developing our recommendations, having got all this evidence together, that was that, well, certainly racialized minorities at high risk of mental ill health, sorry, that these excess rates are probably related to social disadvantage, but also discrimination, including racism. And a lot of the racism is structural and institutional. It's not overt, and therefore the impact of it is very easily understated and missed. And as I'm sure someone's probably already thought about this quote from David Williams, who said, multiple aspects of racism relate to each other and interact additively with other psychosocial issues to affect health. So I like this quote from Galton, who talked about structural violence. And when he talks about structural violence, he was saying that there are these social structures and institutions that harm the health of populations. And these create barriers to resources that enable individuals to meet their fundamental developmental needs. And I think the main thing to say, and Craig Morgan said this, that these social conditions and experiences are not randomly distributed. You know, there are these historical processes that mean that certain groups of people are poor and remain poor. And there is a systematic marginalization of these groups. And it's so ingrained into our processes and procedures and policies that we don't notice it. It just is what it is. In the same way that it used to be that a man owned his wife, she couldn't testify against him. If she left him, he automatically got the kids. He got custody, things like that. The structures which keep marginalized people marginalized. So that was the background from our recommendations. And essentially, we felt that there were non-specific recommendations that we could make, essentially because so many more Black people and were more like, we're going to be, so many more Black people were sectioned anyway. Anything that would help to reduce detention rates would and reduce restricted practice would obviously help Black people.
Just 2 minutes, Shubulade.
Okay. And then there were the specific recommendations which were aimed at addressing racial disparities. And what we realized is that those racial disparities could only really be addressed at a much broader, wider societal basis. So I'm just going to quickly go through the recommendations. Is the organizational competence framework. This is something that organizations can use to transform the way in which they work, so they can improve access and experience and outcomes for people from Black and minority ethnic backgrounds. We said that there should be culturally appropriate advocacy, tailored interventions for Black children, because Black children are much more likely to be excluded, along with Gypsy children and children from traveller communities. And as soon as a child is excluded from school, it tells you that they are falling off the trajectory of life. And actually, they're much more likely to end up in the high end of mental health services and in the criminal justice system. And so, and what we found was that there's hardly any work around that. But these kids who were being excluded, especially the ones in primary school, you would say there's a problem with this kid. Actually, what was happening is that they were being diverted into the criminal justice system, and then they're lost. We think that there should be more representation of Black people in certain professions, particularly psychology and occupational therapy. And also, very importantly, we talked about piloting and evaluation interventions, behavioral interventions to combat implicit bias. It's not enough to do unconscious bias training. Unconscious bias training just lets you know that, guess what, you've got a prejudice against a certain group of people. You've had that for 40 years of your 40-year-old life. You're not just going to change it in a couple of hours of unconscious bias training. So we have talked about developing behavioural interventions to combat that. And also, there's something about the funding for research. There's a real problem with research and the way in which the research is done. The ideas are not generated that probably take into account the needs of all the people who the research is meant to help. So we essentially talked about an equity-led approach. Just to very quickly at the end, to say that the Royal College of Psychiatrists has now published a new Equality Action Plan. And one of the big things that we're going to be doing is looking at the curriculum and looking at differential attainment and thinking about how we can support organizations and how organizations can influence and change in a way that's equitable for all, basically. And the core and higher training curriculum is now going to be changed so that it means that people, sorry, I'm going back here. So it means that psychiatrists are actually not just thinking about clinical diagnoses and psychological questions, but also thinking about the social and societal situation that a person comes from and how that might impact and how the structural inequalities and power differentials within mental health impact that person's care. Okay. So just to summarize, excessive rates of mental disorder are seen in those who are socially advantaged and discriminated against. All types of racism associated with increased risk of mental ill health. If you're from a visible ethnic minority, it probably increases your risk of developing adult ill health, physical and mental ill health later in life. Childhood factors are very important, and particularly important for young Black boys and who show emotional and behavioural disturbance, should be referred to CAMHS or should get some kind of assessment rather than going down the youth offending service. And addressing these structural inequalities is the way forward, essentially. And this is what Sir Michael Marmot said: health inequalities and social determinants of health are not the footnote to the determinants of health, they are the main issue. Thank you.